Welcome to the Adelaide Biomed City Research Mini Reviews. And today's review is from the University of Adelaide and Central Adelaide Local Health Network and focusing on coronary syndromes. But we begin by acknowledging the Kaurna people, traditional custodians of the land on which we meet today, and pay our respects to their elders past and present. And I extend that respect to Aboriginal and Torres Strait Islanders people here today. And my name's John Beltrame. I'm a cardiologist working within CALHN and also the Michelle Professor of Medicine at the University of Adelaide, as well as being the Director of Research within CALHN. And today's program is going to focus on coronary syndromes. And we'll commence with Associate Professor Rosanna Tavella in a moment, detailing the utility of the CADOSA Registry in coronary research. And then you'll have to put up with me talking about our group's research on coronary vasomotor disorders. So a little bit about Rosanna. So Rosanna's an outstanding mid-career researcher who's established and manages the CADOSA Registry, which is internationally acclaimed, as well as having key roles in the safety and quality monitoring at CALHN. She has an extensive international collaboration and indeed began the day at 7:30 this morning on a Zoom link with one of our international partners who has an international reputation for his health outcomes research. So without any further ado, I'll hand over to Rosanna. Thanks, Rosanna.
Thanks, John. Thank you for the introduction and for the invitation to speak here today. Okay, so CADOSA. So CADOSA is a flagship clinical quality registry for patients undergoing coronary angiogram or coronary stenting procedures across South Australian public and private hospitals. So just briefly, there were three modules. Oops, just having some trouble with my PowerPoint. Three modules. There we go. Sorry. There are three modules attached to the CADOSA program. The first being the Clinical Quality Registry, which is an extensive baseline data collection where we have dedicated site managers at each of the sites collecting this information. And this data is then linked using administrative data sets to track clinical outcomes following discharge over 12 months, so mortality and return hospital visits. Secondly, the patient health outcomes module focuses on patient-reported outcome measures using validated questionnaires looking at both disease and generic, disease-specific and generic health outcomes. And again, we look at this at baseline and then assess this across over 12 months for patients using telephone follow-up. And lastly, we have a biobank. So this is an integrated long-term storage biobank for both blood and genetic material that's available currently for current studies, but also for future cardiovascular research. So some of the key attributes of CADOSA are our links with international and national partners. So firstly, the CADOSA clinical data is modelled on the National Cardiovascular Data Registry, or the NCDR. And in fact, CADOSA is completely compatible with the cath-PCI registry within this, this organisation. So the NCDR is really the premier cardiovascular data bank organisation run by the American College of Cardiology. And CADOSA is one of few sites outside of the US that is recognised as an official affiliate site of the cath-PCI. And this really provides us with opportunities to undertake international benchmarking of care, and also provides us with opportunities to validate clinical risk models that have been developed by this international society. So locally, CADOSA contributes to the Australian National Cardiac Registry, and this is a Commonwealth-supported initiative that is looking at developing national databases for cardiac procedures. Now, in relation to our health outcomes, CADOSA is collecting the full ICHOM set for coronary artery disease. ICHOM is the International Consortium for Health Outcomes Measurement, which is a Harvard-based organisation aiming to redefine the value in our healthcare system, and is really trying to do this by emphasising the need to measure patient-reported outcome measures, or PROMs. And so we have a measure to look at how disease is impacting the patient from their perspective. So CADOSA is one of few sites also worldwide that's implemented the full ICHOM standard set for CAD, which looks at endpoints of angina, depression, shortness of breath, mental and physical functional status, and overall health-related quality of life. So CADOSA has enrolled over 2,000 patients in the PROMs component, and we've been really pleased with the how we've maintained follow-up of these patients, with reaching over 90% engagement still at the 12-month point. So how is CADOSA contributing to research? So the first example I'd like to share comes from our biobank, where we've done some work with our colleagues from the University of Adelaide, Dr. Peter Zalewski, who's done some really innovative work and has developed a novel endothelial cell biopsy technique. So endothelial cells line the vessel wall of the coronary arteries, and from the wires that are used during the coronary angiogram, we've developed a technique that allows us to harvest cells and with a very, very high yield. And this method has just recently been published in one of the key cardiology journals. The second example I'd like to give is in relation to therapies and clinical trials, but in the space of the registry-based randomized clinical trial. So the registry-based RCT is really a new and evolving methodology to conduct clinical trials pragmatically and also cost-effectively. So CADOSA has been very fortunate to be working with the Sweetheart Group. So Sweetheart is a real powerhouse group of registries based in Sweden, which has a national acute coronary syndrome database that's been running very successfully for a number of years. So our collaboration with Sweetheart, we have actually implemented an international registry-based randomized controlled trial, and the first one of its kind in the cardiovascular setting in Australia. This trial is looking at patients with a condition called MINOCA, which stands for myocardial infarction with non-obstructive coronary arteries. And I'm sure Prof. Beltrame will share a little bit more about these patients in his talk. But briefly, these patients present with a type of heart attack where we really have a limited understanding of what the best evidence, what the best treatments are for these patients. So this trial is trying to understand whether our traditional cardioprotective agents are of benefit with patients with MINOCA. The next example I'd like to share is in the space of personalised medicine, but not in the sense of using biological information from patients, but using the information we have in terms of their clinical profile. So the PAMICO project is an NHMRC funded partnership grant, which is looking at improving 30-day outcomes in patients presenting to hospital with acute myocardial infarction by personalising their care with clinical risk prediction models. So there are three components to PAMICO. The first is designing and implementing risk stratified clinical pathways. And these pathways will be guided by an individual's clinical risk profile. So by using routine information that we have available about the patient, we'll be able to calculate a number of clinical risk prediction models that can be used to stratify their care during the admission. And these components are then will then be overlaid by a very intense monitoring of care feedback loop back to clinicians. So this will include looking at whether we're meeting the Australian Commission's of safety and quality clinical standards for acute coronary syndromes. And we'll also be looking at traditional 30-day clinical endpoints and 30-day patient-reported outcome measures using the CADOSA infrastructure. So as an example, this is an example of a risk model looking at predicting length of stay in patients who present with acute myocardial infarction in hospital, developed by the National Cardiovascular Data Registry. So using our CADOSA data, we've been able to look at validating this model with the NCDR and also recalibrating the model to ensure it's fit for purpose in our local healthcare system. And you can see the clinical variables on the screen are really quite simple data elements that are available routinely and quite early on in an admission. So at the start of a patient's admission, with this information where we have a predicted or an estimated length of stay, we'll be able to streamline a patient's discharge pathway according to whether they have a short length of stay, or they can be fast-tracked for early discharge, a standard length of stay, or a long length of stay potentially needing rehab or a nursing home following discharge. So how does this all come together? So we're integrating the CADOSA infrastructure, our routine clinical data, and we're using a digital health technology solution called ePrism, which is really a bespoke technology platform that's been developed in the US that has the ability to run multiple clinical risk models at one time for an individual patient. So, and in addition to looking at process measures like length of stay, we'll be able to receive estimates of risk for clinical outcomes like readmission, and also procedural complications like bleeding risk and risk of acute kidney injury. And using this platform, this information, it can be relayed back to care teams using visual support aids and decision support tools. And it is also made available to patients through an information sheet with information integrated into the patient's consent form. So this really enables shared decision-making between care teams and patients, and provides care teams with that scientific information at the point of care to risk stratify an individual's care. So PAMICO is really a step towards futuristic healthcare. So this collaboration between CADOSA, SA Health and ePrism is really looking at how we can use simple clinical information about an individual to enhance their treatment at the point of receiving their care during their hospitalisation. So with that, I'd just like to conclude my talk and acknowledge firstly our funding partners, our research collaborators, and also the large team, our large project team across the multiple hospitals, support from the cardiology and cath lab staff, and our chief investigators contributing to our steering committee. So thanks for your attention, and I'm happy to take any questions now or at the end of the talk.
Thanks very much, Rosanna, and it's a real credit to you, the extensive work you've done to establish CADOSA, which is certainly is well known and respected across the world. And maybe, so just draw to people's attention, if there's any questions, there's the Q&A function, if you just put your questions in there. But while people are thinking, I guess, what are some of the challenges you've had in managing the CADOSA registry?
It's a great question. So lots of challenges, but also lots of positive outputs. So certainly lots of challenges administration-wise. So we have quite a unique model in that our the funding that we have obtained for the registry has been used to set up a sort of a dedicated team of registry staff who have a primary role in collecting the data. So there's certainly administrative challenges in terms of accessing information and establishing secure storage of that information, so secure database, etc. Ensuring that we have appropriate access controls in relation to using the data for research purposes, having a data governance model. So certainly that it has been challenging, but also very rewarding at the same time. So yes, so certainly a lot of challenges in the beginning, but I feel that now we have quite a nice, well-running machine here.
Okay, so certainly a bit more to it than having an Excel spreadsheet.
That would be much easier.
Okay, all right. I don't think we've got any questions, and time's moving on, so we might go on to the second presenter, which looks like is me. Okay, so I'm going to take you on a whirlwind tour of some of the other research that we do within the group, which focuses on the coronary vasomotor disorders. And what you're going to see is that this is really a different perspective, a different form of heart disease, which has taken many years for cardiologists to recognise. So in conventional coronary artery disease or atherosclerotic coronary artery disease, we have clinical presentations, acute coronary syndromes such as heart attacks or myocardial infarction, and chronic syndromes such as stable angina. Usually the pathophysiology that's involved is an obstructive atherosclerotic lesion, as shown in the picture here. And usually this has to be more than 50% to be significant. And then in the acute coronary syndrome, there's an atherothrombotic process. And we have very well-defined clinical management pathways in guidelines to manage these patients. But what happens when we have a patient presenting with chest pain, we do an angiogram and we don't find any significant coronary artery disease? Unfortunately, what happens too commonly is that the patient's labelled as having non-cardiac chest pain, the cardiology discharges them and sends them back to the general practitioner. Yet some of these patients can actually have cardiac pain. This has frustrated patients so much that they have formed their own support groups. And here's the two international ones. So there's ANOCA International and the International Heart Spasm Alliance. And we certainly have a lot to do with both these groups, who are at the forefront of educating patients and to some respect also clinicians in relation to what should be done with these patients who have chest pain but no significant obstructive coronary artery disease. So there's two aspects that I'm going to cover. So firstly, we have the patients that present with an acute coronary syndrome and a myocardial infarction. And as Rosanna has alluded to, these are patients with MINOCA. And then we have patients with INOCA, which is the chronic coronary syndrome. So these are patients that have stable angina with evidence of myocardial ischemia often, but again, no obstructive coronary artery disease. And instead of labeling them as non-cardiac chest pain, what we should be trying to do is evaluate the underlying cause, so then we can direct treatment towards the underlying mechanism. So firstly, I'm going to focus on MINOCA. So this is an ECG for the clinical people online. This is an inferior ST elevation myocardial infarction, which would warrant emergency angiography. And when we find a nice tight lesion like this, we know that we need to angioplasty it and stent this. So that's fairly straightforward. But we can have the same ECG and we do the angiogram and the patient shows no significant obstruction. Unfortunately, what often happens is these patients are labelled as a false positive ECG when exactly the same ECG results in obstructive coronary artery disease. And when we try to work out the way to manage them, instead of labelling them as MINOCA, this is usually the clinician's response, not quite sure what to do. So the first step, and this again, because what I'll repetitively show is how Adelaide has been at the forefront of a lot of this research. So the term MINOCA actually came from Adelaide. So this was first coined back in 2013. But the key study was undertaken by one of the university's PhD students during her thesis. So this is Thashi Pasupathy, and she spent considerable time doing a systematic review, looking at patients that had suspected myocardial infarction, but no obstructive coronary artery disease. What she found is that this represented about 6% of the heart attack patients. Women were overrepresented, they had fewer risk factors, and the prognosis was better than patients that had an infarct with obstructive coronary artery disease. She also went on to look at some of the underlying pathophysiology. So this paper, this seminal paper, then stimulated a lot of research in this area and interest in MINOCA, because now we had a label, we had the clinical characteristics. And so as a consequence, firstly, with the Europeans, developed a position paper on MINOCA, defining what it was, that it's patients with myocardial infarction, non-obstructive coronary arteries, and no obvious cause for the presentation. So if we did it in the Europeans, then the Americans also had to do it. So again, we were involved again in formulating the guidelines for MINOCA from the American Heart Association. And then, as Rosanna's mentioned, we've also now undertaking MINOCA-BAT, which is the first randomized clinical trial of patients with MINOCA. And again, Adelaide was the first site in the world to enter a patient into this trial. And building on what Rosanna mentioned, the way that MINOCA-BAT works is that there's Sweetheart, which is a very large registry within Sweden, and then CADOSA. And so utilising the infrastructure of these registries, we then built the randomisation, which is basically either neither of these treatments, beta blockers alone, ACE inhibitors or angiotensin receptor blockers alone, or both. And so by having this infrastructure, we're able to look at the outcomes in these patients. Now I wanted to move on to INOCA. So the key things is that INOCA, so this is people with stable angina. It could be due to coronary artery spasm, or it could be due to microvascular dysfunction. And first I'm going to focus on the coronary artery spasm. So one of the techniques that we undertake is provocative spasm testing, where here's the this is an angiogram of the right coronary artery. And then after we try and provoke spasm with acetylcholine, this is the lowest dose, you can see that there's severe spasm involving the right coronary artery. And so this is a positive test. And so we then formed Covardis. So this was co-founded between Noel Barry-Merz and myself, and this is an international group to basically promote international collaboration, but also to try and establish the nomenclature so that we had the same nomenclature across the world. So the first paper we produced was to standardize the diagnostic criteria for vasospastic angina. And so that the key characteristics is you had to have nitrate responsive chest pain, you had to have ischemic ECG changes, and then evidence of coronary spasm on angiography. So as well as that, we then established a coronary spasm, an international coronary spasm registry. And again, Adelaide was in the lead here, recruiting patients for this registry. Now I'm going to move on to the microvasculature. So whereas in coronary spasm, we can visualize the spasm on coronary angiography, the microvascular we can't see. And so we have to rely on other techniques such as measuring coronary blood flow to infer what is happening in the microscopic blood vessels. So the typical scenario is that if you have a patient undergoing an exercise test, in this case we have a male undergoing the exercise test, this is the baseline study. Here you see ST depression, which is suggestive of myocardial ischemia. If you undergo angiography and again you show a lesion, we know what to do here, we do PCI. But if we reverse the roles and now it's a woman undergoing the stress test, again the same ECG changes and we do the angiogram and there's no obstructive coronary artery disease, then what used to be said is this is typical. This is typical of a woman who has false positive stress test. Yet the stress test is showing you ischemia, whereas the angiogram is showing you coronary anatomy. And what the question we should have been asking is, well, it's not due to obstructions in the large coronary arteries that the ischemia is derived, and perhaps it could be the microvasculature. And so this is an example of INOCA. So again, with the Covardis group, we then tried to standardize the diagnostic criteria for what we call microvascular angina. So angina arising from the microvessels. So that you had to have evidence of myocardial ischemia, no evidence of obstructive coronary artery disease on angiography, objective evidence of myocardial ischemia, such as a positive stress test, and then evidence of impaired coronary microvascular dysfunction. And so that's an impaired blood flow study. Again, the Covardis group, having established the criteria, then developed a registry. And again, Australia and particularly Adelaide was represented in this registry. And the observations that we made is looking at major adverse cardiac events. So this is over a period of 5 years, where major adverse cardiac events is cardiovascular death, non-fatal myocardial infarction or stroke, or hospitalisation for unstable angina or heart failure. And in reality, a lot of the major adverse events were due to unstable angina. But here you can see that the women have more events than the males do. Also that you can see that the Caucasian patients tended to have more events than their Japanese and Korean counterparts. Next, I wanted to cover the coronary slow flow phenomenon. So this is something, again, that's been characterized in Adelaide in particular, because previously it was just considered an angiographic curiosity. So you can see why it's called slow flow, because the dye moves very slowly in the angiogram. And whereas some of my colleagues considered that this is the way you were injecting the dye, we kept believing that there must be a problem here, and this slow flow is a reflection of a problem in the microvasculature. And so this was often regarded actually as Adelaide disease. So we undertook a key study where we had 20 patients with coronary slow flow and undertook a randomized, double-blind, placebo-controlled crossover study. So, and all the patients had to have slow flow and at least experiencing angina 3 times a week. So they were randomized to placebo or mibepridil, then a 1-week washout, and then crossed over to the other side. And the key endpoint we were looking at was the angina frequency. So this is one of my favorite slides, because what this shows is the phase of the study, okay, and how frequently they were experiencing angina. So in these patients, the ones that were randomized first to mibepridil, so in the first phase here, you can see the angina frequency improves, but as soon as they're in the crossover and on placebo, they're experiencing lots of angina. Whereas the patients that were randomized in the reverse direction, lots of angina, but as soon as they get mibepridil, it improves their chest pain. So now we had a treatment for angina, but unfortunately, as soon as we found this out, the drug was withdrawn worldwide because of post-marketing surveillance, realised some problems with drug interactions. So we continue to look for other drugs to treat the condition. I mean, mibepridil was effective, but not available. We're currently done a trial with dipyridamole. We're currently undertaking one with ticagrelor, and also with the endothelin blockers. Also, other innovations that we've got with this group is that within the Cardiac Society of Australia and New Zealand, we've established a coronary vasomotor dysfunction working group. So on a national basis, there's now interest in this area, and we're trying to standardise the clinical assessment protocols. So we have a manuscript in preparation there. We're going to develop a consensus statement concerning these disorders, hope to establish a quality registry here also, and then as well make available some of these techniques through the MBS. So to finish up, what I wanted to show is that, you know, Adelaide is really an international leader in the area of MINOCA and INOCA. So in MINOCA, we coined the term, we characterised this disorder, we contributed to the European and US guidelines. We have a strong collaboration with our Swedish colleagues in doing the MINOCA BAT study. And as mentioned, we're the first site in the world to recruit a patient to a MINOCA study. But then also in INOCA, we've established the vasospastic angina diagnostic criteria, the microvascular angina diagnostic criteria. We're responsible, again, here in Adelaide for characterising the coronary slow flow phenomenon. We've had links with international registries and contributed to them, both in spasm and microvascular dysfunction. We co-founded COVADIS, and as well, we've now, on a national basis, established the Coronary Vasomotor Working Group. And we're in constant contact with the INOCA International and the International Heart Spasm Alliance for trying to look for treatments, but also assist them in educating the patients with their problems. So that's a quick whirlwind tour of Minocra and Anoka, but really it's a big team effort, and these are many of the team players that have been involved in contributing to the work that I've shown. So very happy, stop sharing, very happy to take any questions. But if there's no questions, we're right on time. So firstly, I'd like to thank Rosanna for her presentation. Again, thank the people who participate in our studies, both the patients and the researchers. And thank you for listening. And I hope that we've shown you some of the research work that our team does, both in relation to healthcare, in CADOSA, but also in terms of coronary artery spasm and microvascular dysfunction. And I hope that you've seen that Adelaide has really been one of the leading centres around the world for both these technologies. Thank you very much.